you, Dr. Taniawi, and thank you. Good morning, everybody. So, of course, we're going to talk about PMTCT, but particularly in the era of COVID-19, and there's a lot of adaptation, a lot of information to share. And we have three excellent panelists who are going to tell us about their experiences and their expertise with respect to their respective countries. So I'll start with, and by naming them, I'll invite them to come up to the stage. I'll start with Dr. Angela Mushavi, who is the National PMTCT and Pediatric HIV Care and Treatment Coordinator in the Ministry of Health and Child Care, and has been providing technical leadership and guidance for the expansion of PMTCT and pediatric HIV and AIDS care and treatment programs in Zimbabwe. She is involved in policy and guideline development at national and international levels, and is a member of the WHO ARV Guideline Development Group. Thank you and welcome, Dr. Mushavi. Next will be Dr. Aleny Couto. Dr. Couto is the head of the STI and HIV/AIDS program at the Ministry of Health in Mozambique, with experience in the management and implementation of national and provincial level health programs, with a specific focus on HIV/AIDS, as well as designing policies, country guidelines, and strategic plans following WHO guidelines. Dr. Couto has participated in the expansion of an HIV scale-up plan and also implemented a wide range of public health programs. So welcome, Dr. Couto. Good morning. Good morning. And last but not least, who will be joining us virtually is Dr. Ameena Goga, who was the director of the HIV Prevention Research Unit at the South African Medical Research Council, and recently joined the WHO as a pediatrician in the Health and Development Unit research team. For the past 10 years, her research has focused on improving mother and child health and preventing vertical HIV transmission. So you can agree with me that these are three excellent resource people who will be discussing this topic with us this morning. So you are all welcome, and Dr. Goga, you are welcome virtually as well. So how we will go about this is to first have them present, short snapshots from PowerPoint presentations on how they have handled PMTCT, especially in the era of COVID-19. So I'll start off by having Dr. Angela Mushavi do her presentation, followed by Dr. Aleny Couto, and then later on, Dr. Ameena Goga. And then after that, we'll have a panel discussion. So Dr. Mushavi, go. There's a screen right here. Oh, okay.
Good morning, colleagues. I'll be too high. I'll stand. Yes, it was nice last night to have the networking dinner, and I'm glad that I'm here kicking off the presentation for today. I have no conflict of interest to declare. And basically, the outline will be sharing some data from Zim, some numbers on the COVID-19 situation in our country, and then the impact assessment findings that we did to understand the impact of COVID-19 on essential service provision, including HIV, and then some of the challenges and mitigation strategies. I have very few minutes to speak, so I won't be reading through all of my slides, but Zimbabwe is a high HIV burden country with a prevalence of 11.4% and a mother-to-child transmission rate of 8.7%. This data is from 2020. In 2021, we actually saw an uptick in the mother-to-child transmission rate to 8.9%. And much like the data presented yesterday, we are not doing very well with pediatric ART. We have adult coverage at 94%, pediatric coverage at 73%, and ART provision to pregnant women sitting at 87%. This is a downhill compared to pre-COVID, and you will see some of the numbers in some of the slides and how we were impacted. But prior to COVID, our ART coverage for PMTCT was 93%. And we have a large population on ART, 1,128,000 people receiving antiretroviral treatment. For COVID, we reported our first case in March of 2020, 20th of March. And as of July 2017, we have recorded 256,000 cases of COVID, 5,576 deaths, and our case fatality rate is 2.2%. We are vaccinating with about 6 million people having received the first dose, 4.7 million received the second dose, and just under 1 million received the booster. We did a COVID-19 impact assessment a few months after the first case was reported in June of 2020, and then we did another follow-on assessment in May of 2021 just to understand whether the system was responding to the challenges of COVID-19. And basically, we wanted to assess the impact of COVID on HIV service delivery. And then on the 26th of March, after the first case was reported, Ministry issued rapid guidance on implementation of essential HIV services in the context of COVID-19, which were to be implemented in conjunction with the Zimbabwe Preparedness and Response Plan. And this is some of what happened to our women and the data that comes from the District Health Information System, the program data. If you look at when we implemented, I don't know if the pointer works. It's not working. But if you look at the month of April of 2020, remembering that the first case was in March, you can see the drastic drop in first ANC contact. Really remarkable. And then in between, at that time, we also had travel restrictions imposed because we were on level 4 lockdown. And then we slowly rebounded after the lockdown. We had another upsurge in cases, and you can see this time round in the second lockdown, a less attenuated decline in ANC attendance. And this graph compares what happened in the year January to December of 2018, of 2019 and 2020, and in the blue, you can see what happens to the booking of first ANC with the first lockdown in April and subsequent rebounding back of ANC attendance. As we speak, our ANC attendance seems to have stabilized, and we hope that we'll get to pre-COVID levels soon. So the ID samples collected, I think the same drop follows because the mothers bring the babies, isn't it? So we also saw the same in the post-delivery period, reduction in attendance for maternal and child health services. And this is what has happened to our MTCT rate. Because ART coverage for PMTCT declined in 2020 and 2021, that has had an impact on the spectrum outputs, and our mother-to-child transmission rate is going in the wrong direction at the moment. So we have seen challenges, and this has impacted maternal health, and we have seen also unintended consequences of COVID-19 on service provision for maternal newborn child health. And we have studies that we have conducted in collaboration with University College London, with the University of Zimbabwe, the Ministry of Health and Childcare, with OFID, as well as the Queen Mary's Hospital or University in London, to understand. And I think Sesha came in also to do like a qualitative interview of mothers who were affected by COVID during those time periods that I mentioned. So the challenges are at program level, at individual level, and at health system level. And basically, at the beginning, facilities had to be repurposed to be able to handle COVID-19. That means some ANC sites were closed or they were converted to isolation facilities. And there was really a derailing of program implementation. We had a work from home policy, and a lot of people had challenges with internet connectivity. And then, of course, there was impact on the supply chain for diagnostics and antiretrovirals and other commodities. At an individual level, because mothers were afraid, I think all of us were afraid at the beginning of the COVID-19 pandemic. It brought everybody to a standstill. And so we saw late or reduced uptake of PMTCT and other essential services because of fear, because of uncertainty whether women were going to find a service if they arrived at a health facility. And the transportation was severely curtailed. People had to use innovations to travel, like riding at the back of a tractor or a truck just to get transportation. Now you can imagine, can a pregnant woman jump onto the back of a truck, carrying a baby post-delivery, going to postnatal care? So we saw an increase in home births and home deliveries and late presentation for ANC. And of course, the increase in gender-based violence, which was documented, including lack of access to family planning. And we have seen, with the way schools were closed, an upsurge in teenage pregnancies because children were not going to school. They were confined in the home, and a lot of things happened during that time. And of course, psychosocial, the fear, the confusion, and the mixed messages, particularly for pregnant and breastfeeding women regarding the vaccination. At a health system level, of course, our facilities were inundated. They were overwhelmed because of the inadequate infrastructure for isolation, the shortages of PPE, the reduced healthcare workforce, whether that was downtime from having COVID or stigma. Our healthcare workers were stigmatized. Some people actually chucked them out if they were renting because they worried about contagion. A healthcare worker coming from a facility to stay in a home, they didn't know how that would impact them. And at that time, we also had some industrial action by healthcare workers during the 2020 period. We noticed an MMed-related challenge. There was limited documentation of even the services that were provided. So healthcare workers were so overwhelmed, there was no time to fill in the registers, compile the summary return form, and then enter it into the district health information system. And therefore, we think some of that drop might also be underreporting. And then, of course, the compromised quality of care. So we have kind of like moved on. I think this stopped moving. So in terms of, some of the opportunities we have and some of the initiatives that we implemented to make sure that we implement activities and go back to full service provision.
Yeah, it's coming.
Okay, all right, thanks. I was going to read from my laptop. So the opportunities, we had the rapid guidance to implement essential services. We scaled up program remediation to recover from lost gains, showing, improved program resilience. And then we put in tracking and tracing systems for defaulters. We had community-based outreach versus clinic-based services so that we could cater for those who couldn't travel. And then we started DSD models, including multi-month dispensing to pregnant and breastfeeding women and children. And we used virtual platforms to convene some of our meetings, such as the National Validation Committee, etc. And we also introduced an app, the Hello Mana, which is a digital platform to support pregnant and breastfeeding women. And we went on radio, community and national radio, to tell people that services, essential services, were still available. And these new ways of doing business, we will continue, like on-job training, mentorship, rather than bringing people into a big room such as this one. And of course, we continued to resource mobilize, including application to the Global Fund under the COVID-19 response mechanism. So thank you very much. If you move to this next slide, I acknowledge all of the support, and I thank you for your audience.
Thank you so much, Dr. Mushavi, for your sharing in a very short period of time what you've done in Zimbabwe to manage PMTCT in the era of COVID-19. Now we will hear from Mozambique, Dr. Aleny Couto.
Bon dia. Good morning. I'll go straight since we have 5 minutes. What I have to say is that in Mozambique at this time, we estimate that we have 2.1 million people living with HIV, with a prevalence of 13.2% at age of 15 to 49 years old. For those ones, those 2.1 million, 84% of those are diagnosed with HIV, 84% are on ARVs, and only 74% have viral load suppression. But also, at the same time, in terms of vertical transmission, we're still high. Our vertical transmission rate is still at 12% in 2022, so it's still the same. And we are slowly decreasing the transmission from mother to child. But in regard of COVID, we still having cases of COVID. Till July 17, we saw that 229 cases of tested positive cases of COVID in country. Most of them recovered, only 2,000 deaths. But you know what is the problem in terms of data. So we're saying that we had COVID, yes, we had 4 waves of COVID, but HIV still a very big burden for the country. So what was done at that time? We had 2 levels of interventions. We had intervention at higher level, which is the government interventions. We said that we have to, at this moment, mandatory face masks in closest places, social distancing, borders are open, but COVID test results is a mandatory to enter the country. Universities and schools are now open because they were closed. Public space, sports, religious service, and celebrations now are allowed to happen with a restricted number. But at the same time, we have to make changes within the health facilities quickly to really adapt to the COVID pandemic. So we had to change the patient flow for the chronic disease, in this case, mainly for HIV. We had to make changes at reception. We had to give information about COVID, how to protect about COVID. And also in the waiting rooms, we had to do all this information about COVID and sometimes do the COVID screening in order to refer for testing. At the clinical consultation room, we had lay counselors to give psychosocial support. Since we have a short number of psychologists in country, we use lay counselors to have the psychosocial support. We had to do nutritional screening that by the clinician. We have to offer a package of service that is necessary to be done. But also, at the same time, the main thing is that instead of going to the pharmacy to pick up the drugs, what we have done is that we move the pharmacies to the clinical consultations also, where it's all possible to be done. In terms at the community activities, at the beginning, on the first wave, we stopped doing the community activities. But the second, the third, we really have to think very fast. That the first case of COVID was in March 2020, and what the country did was doing all this changing of flow, but at the same time, we had to think how we can deliver community activities, and that was done after 2 months. But also, AJ, I'll come back. But also, like in Zimbabwe, we had to have circulars in place to saying that which services have to be protected. And also we had to do a lot of communication because the message of stay home was a big message and people were staying at home, but we really have to protect what is necessary, mainly for the PMTCT. So what was the impact on PMTCT? First, as you said, the antenatal care attendance, it dropped a little bit in 2020. I see, but we work with estimations in our country. That's why we have these high numbers because of the estimations that we use. We're saying that every year, 5% of general population are pregnant women. So these sometimes can not be very good, so our denominator can be affected. But what we saw is that in terms of antenatal care attendance, it was a little bit of drop in 2020. That was because of COVID, but that was for a short time. But also in terms of HIV testing, what we saw comparing from 2020 and 2019, till 2021, we saw that there was not any decrease in terms of testing, and we saw that what we only saw that is that retesting for pregnant women is where we saw most of the decrease, because we have to adjust the time of coming to the health facility. What we did most of the time is that the pregnant women and lactant women, we have to offer 3 months drug dispensing, and so with that versus what the antenatal care was affected, so that's why, but in terms of offering testing, there was not affected. But also in terms of ART coverage, HIV pregnant women comparing, we saw that there was no change on that, because we are still offering, for those women that came to the health facility, we're still offering the ARVs. In terms of early infant diagnosis also, there was not such a big difference on the last 3 years, 2019, 2020, and 2021. And remember, in Mozambique, we have a point of care of early infant diagnosis, so that on time we can do it, and on time we can provide the results. But where we saw the really big problem was in the early retention. I said the first case of COVID was in March 2020. You can see that at 33 days, the early retention dropped from March, it was 81%, it dropped to 76%. So there where we saw the problem. So what we did was that we had to issue the circulars, we had to do a lot of demand creation, we had to do a lot of information, spots, radio spots, and all that. That's where we saw that the women have to come back to the health facility. That's where we saw in May 2020, again, an increase in terms of early retention at 33 days. And we didn't see any changes at 99 days of retention. So in terms of starting early ART on those ones are HIV positive. Here we use the quality improvement data. What we see is that comparing from 2029, 21, and 2021 midterm review, because we're doing the cycles of quality improvement, what we are seeing is that within 2 weeks after the diagnosis, even you can see that in 2019 was 77% and was increased 86% in 2021, but in midterm of 2021 dropped again at 79%. So that it changed sometimes, and that has to do also with the data, quality of data that we have. So what were the challenges? In terms of PMTCT, I saw the presentation of what was in general, but can be affected in Zimbabwe. But in terms of PMTCT, based on the data that presented here, what we saw is that we reduced the access of MCH service for a short time, as you see as an early retention. But there was a challenge also to ensure alignment between offering ART and antenatal care consultation. We had a really big fight with MCH people, because we have to protect what's the outcomes of MCH, but also at the same time we want to protect our pregnant women that are living with HIV. How to deliver 3 month drug distribution versus with the monthly visits antenatal care. But at the beginning, on the first wave, we agreed that we really must give 3 months drug distribution, but afterwards, after those, at the second and third wave, we have to really go back so in order to protect the monthly visits of antenatal care. But at the same time, we do negotiate that we can still deliver 3 month drug distribution, as long as we say that women, she must come every month. But also, we had to challenge on the follow-up of the exposing children to have the definitive diagnosis, since we changed the time to coming to the health facility, and also the times of coming to do the immunization on children. But what were the opportunities? This time was time to really pilot and see if DSD is possible to be done at pregnant women. So DSD for pregnant and lactant women, we saw that it's possible to be done. And as a country, we're going to adapt to be done in emergency situations, since we know that we have emergency situation in north of Mozambique, like in Cabo Delgado, we have a war at this time. So it's time, is an opportunity that is possible to give at this time 3 month drug distribution. What we saw, the opportunity is the calls with the provincial teams to monitor PMTC key indicators. So monthly calls are done to discuss all the new recommendations. That was something that we really have to be close monitor in order to protect everything in terms of gains on PMTCT. Communication with the recipient of care also, we saw that is very key. So what's very key for having video, radio spots, WhatsApp, Facebook meetings with community leaders in order to say that, yes, you have to stay at home, but you have to come to the health facility to have all the package of service that is necessary. And offer service by phone. Mainly the psychosocial support was something that we cannot, because the community activities were stopped, we could not visit women, so the mentor mothers, they have to call those ones that have phones. Only 30% of population in Mozambique has phones. So sometimes when you come to meetings, they say, yeah, you have to do everything with phones. But for those ones, we have phones. For those ones we have phones, we could not really reach them. But we have to really talk with the community leaders in order to deliver all the message. So thank you.
Thank you, Dr. Couto, for that very well-worded but quite detailed information on what was happening in Mozambique. So last but not least, I'll invite Dr. Ameena Goga, who will be presenting virtually, to discuss what happened in South Africa, and then we'll have a short discussion to end the session. So Dr. Goga.
From a research point of view rather than from a service point of view, but drawing quite strongly on data from the services. Just to say that I have no conflicts of interest to declare. In the presentation today, I'll be focusing a little bit on globally and then also South Africa to look at MTCT in general. I want to make 5 key points: that vertical HIV transmission through breast milk needs to be eliminated. We need to understand the stacked bar to tailor interventions for EMTCT. And then given the COVID pandemic, is the worst as well as the best still to come? And I'll allude to some global coverage data as well as country data from South Africa, and then make the point that we really need to find men, women, and children who are not accessing care, and that we need to adopt a lifestyle approach. So the first point to make is that despite all the progress that we've made in PMTCT, no priority country is close to eliminating MTCT. And really in some settings, particularly in low and middle income countries, more than 50% of MTCT is now due to breast milk transmission of HIV. And so we really need to prioritize eliminating HIV transmission through breast milk, which means strengthening the postnatal platform. The other point is to understand the stacked bar and to understand the causes of new pediatric HIV infections, not just at global level, not just at national level, but also at regional, provincial, and district levels within countries. So here you see I've just projected 3 stacked bars. One is global, one is Eastern and Southern Africa, and then Western and Southern Africa. I've chosen these because they contribute to the majority of infections. And you'll see that globally, about 22% of HIV transmission to babies is due to new infections amongst mothers. 48% is due to the fact that some moms don't receive ART, so a huge gap. 22% is due to the fact that mothers don't continue with treatment during pregnancy or breastfeeding, and then 8% are mothers on ART but not virally suppressed. And you'll see that that differs slightly as you look at the different regions of the world. And so it's critical to look at the stacked bar for each region, each country, each province, each district, to try and tailor interventions specifically for that setting. And then the question is the worst still to come? So it looks like we are making progress, but here you have ART coverage data amongst pregnant women, global data by region from 2015 to 2021. And what you see is that if you look at the last 3 bars on each region, you'll see that there has been in most regions a slight decline. And I think, and this is with ART coverage amongst pregnant women living with HIV. And I think the point to make is that if we assume that in low and middle income countries, we have about 1.5 million pregnant women with HIV, and there's a 1% decrease in coverage, it actually translates into 15,000 women not receiving care. So that's a really critical point. It's a small decrease, but affects a lot of women. And then these are case rates from South Africa. So I'll move specifically now to talk about South Africa. And these are case rates just from Q1 and Q2 between 2019 and 2022. The first lot of stacked bars is from the entire country, and the rest of them are from each province. The last three of each group is the Q1 and Q2 of 2020, 2021, and 2022. And what you see that for the whole of South Africa, it seems like the case rate has declined. But when you do an in-depth look at some of the provinces, you'll see that between 2020, 2021, and 2022, there have been variations with some upticks in the case rates. And it relates very well to what Dr. Mushavi was saying. They've seen increases in transmission, and we're seeing these intermittent increases in case rates in specific areas. And I think that also then brings into focus, what is the coverage of testing? Because who are we measuring these case rates against? So on the right-hand side, you see a graph, and it shows at the bottom the MTCT rate at birth, and you see the coverage of testing at birth between 2019 and March 2020 was 97.5%. It remained the same for 2020, 2021. And you'll see quite similar for 10 weeks testing, which was about 70% coverage in 2019 to 2020, and it remained almost the same at around 70%, 69.9% 2021. So we really need to look at indicators in conjunction with some of the coverage indicators. And here I'll show you some coverage indicators from South Africa, also answering the question, if the worst to come. This is just for the first few months of COVID-19. So we had our first case in March 2020. And what you can see is there was a significant decline in PHC headcounts amongst children, as well as a decline in the first PCR test at birth. And so that was until June 2020. This is then also until September 2020, where we measured an increase in maternal mortality. This is from a different source of data. This is from the confidential inquiries into maternal deaths. And then looking at the district health information system data, there have been measurements of changes and decreases in contraception prescription between 2019, so March to December 2019, compared to March to December 2020. And that applies to a decrease in contraception prescriptions, a slight increase in first antenatal visits before 20 weeks, but this might relate to the fact that we have had more pregnancies, and as the other speakers have said, particularly more pregnancies amongst younger people, particularly teenagers and some as young as 10 years old due to the school lockdowns. Changes in the number of births, you'll see we have an increased number of births, which substantiates the point that I just made just now. But more worrying, changes in maternal deaths, and this is an increase in maternal deaths. The initial graph I showed you was only until September 2020. This is all the way until December, and this analysis is being updated currently. And then more worrying, changes in the number of HIV tests, so a decrease. So these graphs measure the change, so it's in the negative, so all measuring a decrease in the number of HIV tests. So I think we really need to look to see who is coming to be tested and what is the coverage of testing. There's recent limited data up till July 2022 of HIV testing in children. And here you see the number of tests at 10 weeks and the 10-week testing coverage, which seems to be improving to 77% by July 2022. And the 6-month testing rate seems to have gone up to about 63.7%. So are we recovering? And are we now entering a phase where the best is to come? But what we must realize is that we need to look at the data very carefully. We need to look at numerators and denominators, and the denominator here are those children who were tested at birth. And so we have to make sure that we understand that these only reflect those who access care at birth and get a test. And then lastly, just to substantiate the fact that we need to adopt a lifestyle approach, on the top graph, you see adults who are virally suppressed. Next to it, you see children who are virally suppressed, and you see a big difference, 67% amongst adults in 2020 compared to 40% amongst children. These children will grow up to become adults, and it will be a fiery circle of untreated HIV infection or HIV infection treated very late if we don't address this. Also to note that the majority of these children, about 60% of untreated or not children who are not virally suppressed, are not in just the 0 to 2 year age group, but they are in the 5 to 14 year age group. And so we need to strengthen those platforms. And so we really need to find men, women, and children who are not accessing care for various reasons as a result of either the COVID-19 pandemic or other factors that we now faced with the increase in the price of fuel and transport costs and food costs that are compromising families globally. And so just to come back to the key points, we need to make sure that we address vertical HIV transmission through breast milk. We need to understand the stacked bars to tailor interventions at various levels, globally to district level. Is the worst still to come? And are we yet to see the best? We need to find men and women and children not accessing care. Otherwise, they will remain marginalized, and we have to adopt a life cycle approach. Thank you so much.
So thank you very much, Dr. Goga. So we have just a few minutes left, and for those who are online, if you have questions, please type them in, and then those who are here who have questions. But I just thought I would summarize that we've heard from Zimbabwe, Mozambique, and then from a more research standpoint from South Africa and globally about PMTCT, but with respect to the COVID-19 pandemic. There's one question I want to ask, especially Dr. Mushavi and Dr. Couto, but Dr. Goga, you can answer to if you feel so. But you've experienced all of these things, you know what happened and all that, but I want to ask, what would you change knowing what you know now? What would you change if we went back and you know COVID-19 is coming, you were pre-warned, and you are in charge of the PMTCT programs in your countries as you are, what would you do differently? So, Dr. Mushavi.
That's an interesting question. But I think having gone through the pandemic, we have learnt a few lessons. I think that one of those is how to communicate that services are still available to the community so that they have confidence to visit our facilities. Because one of the things is like people stopped in their tracks. They didn't know whether to come, whether they would find a service or not. And so how can we enhance our communication with communities who need to access services? So in a way, we need to be ever ready to make sure that we are speaking to the people who need to access services. That for me is the key. And then trying to have enablers, of course, for them to then come and visit facilities. The other one is strengthening the health system. Our health systems need to be ready to handle the next pandemic should it come. Thank you.
Thank you. Dr. Couto? Yes. Couto, sorry.
Yeah, Couto.
Couto.
Yeah. Thank you for this question. I think in terms of PMTCT, first we have to learn that PMTCT is not something that stands alone. Is within the MCH, and what I learned is that we really have to knowing that PMTCT is not verticalized. It has to work together with the mother-to-child health programs also in order to deliver what is important. But at the same time, what we saw is that is like Angela said, is what I have is that innovations can be done. I think it's time also to MCH start to not be very comfortable doing things that are very from far. No, they have to really change things within with the program, and also that I think community, despite of stopping doing the community activities, what we saw is that we really need them to deliver the good message also, not just the health facility, because we don't have enough resources to do that. So community, the mentor mothers, not only mother, but group mother to mother, everything that was necessary to deliver that what is important in terms of sensitization, that you really have to come back to the health facility, because at the health facility we have service that can facilitate and reduce your time to come to the your time within the health facility. But also at the same time, I think it was important to know that we can deliver service through phones also, mainly when it comes to psychosocial support. not only because of HIV, but also because of stigma and discrimination in terms of COVID, and of all that. We didn't know that we can do that, like I said, for those who have phones, but we could just have and sit and call to the women and talk to them and tell them that now you're safe as long as you do this and that, wash your hands, you wear a mask, come to the health facility to have your service. And that was something that we never had done before. So to deliver psychosocial support service through phones for the pregnant women and lactant women. Thank you.
Great, thank you. And Dr. Goga, if you can answer that, if you want to use a research aspect too, that would be great.
I don't know about a research aspect, but I think just clear messaging, really clear messaging, because although there were circulars that went out saying that services are still running, many people didn't get the message to say that MCH services should still function. And that was from a healthcare provider perspective, as well as from a user perspective. And so I think, in an emergency like that, very clear messaging that needs to be relayed on all forms of media. And then attention to data. Even as I sat to put together these slides, it was really difficult to get hold of data, either lab data. Lab data was available, but district data, that has been cleaned, or data that has been collected through the epidemic to measure the impact on services, very difficult. So we have to really strengthen that.
Okay, great. Thank you, Dr. Goga. So everyone is talking, about clear messaging, being ever ready, data being available and not looking only at HIV or PMTCT on its own, but MCH and the larger health system. Are there any questions from the live audience? Okay, we have Dr. Mboringacha here, and then another one coming up on the right. So please go ahead.
Thanks for the panel, very interesting. Quick question around GBV and sexual and reproductive health services for the adolescents, because those are the sort of that's the elephant in the room. I love your adaptations, etc., but what can we do differently for this group, and in terms of adapting our services to address these two components going forward?
Are you addressing to any of the panelists? Okay.
Okay, thank you. I think we saw it during the pandemic that the service, sexual reproductive health and GBV, is something that really dropped. And what we saw in terms of violence, that sexual violence increased, is something that we saw in countries. And for me, like for my country, I think those things in terms of, when it comes to GBV, when it comes to adolescents, is that we're still struggling in having the structure of what is in terms of a program of adolescents. They are not in the same, I don't want to say, but they're still far behind what really has to be done in terms of what is essential to be done in terms of GBV. But what we're still talking about what is violence in country, and most of the people, they didn't have this awareness that violence is something that has to be reported and has consequences when we don't report that. So they have to really take action, and they really have to take lessons from the others also. Like us from HIV, we took lessons from other programs, and I think GBV also, they have to jump in and learn that service can be delivered at the health facilities, service can be delivered at community, and to really have to have close monitoring in terms of that. When we don't have the tools to report all that, I think it turns a little bit difficult to do intervention. So monitoring what is happening is something that is very important in order to take action when it comes to GBV.
Thank you. Dr. Mushavi, did you have a comment?
I think that the important thing is empowering, letting people know how they can report cases of gender-based violence. And in our context, we had a toll-free number that could be utilized. But again, that means you have to have access to a phone for you to be able to call out and look for help. And then there was actually a hotline set up through the office of the First Lady where people could report cases and then get help. But I think that people are afraid to report. Some of this is intimate partner violence, or it is violence between relatives confined in this space, and there's also that fear that you need to talk people through. For reproductive health services, including family planning, I think outreach models and utilizing community-based distributors of family planning products is one innovation that we did. We already had them, but we had to increase the number of cadres who could deliver family planning products to people in their homes. But I can tell you it was not adequate. We had a situation on radio where women were crying for family planning because they couldn't access them. They were confined. And so I think we are going to have a COVID baby boom. We've already started to see that with the teenagers and the young people in high rates of teenage pregnancies. So we are not meeting the needs for reproductive health services.
Thank you. Thank you very much, Dr. Mushavi. We would have to skip to taking the last question because we're a little bit more out of time. Please go ahead.
Yeah, thank you very much to the panel. Pauline Amuge from Baylor, Uganda. So a quick one, which actually Dr. Mushavi preempted to answer before I even ask. So in addition to engaging the community to pass on the positive messages and availability of services, I'm interested in the other ways that you engaged them to first of all deliver services to the people that may not have been able to come or are actually not still able to come to the healthcare facilities, and also create demand for the services because as we know, it's not very easy for the young adolescents to ask or to look for SRH services. So how is community being engaged to create demand for such services that are very relevant, but also what are your integration efforts into, integrating EMTCT services into the other existing adolescent-friendly services? I know quite a number of PEPFAR-funded countries are implementing the IAPS program. I don't know how much of that you're taking advantage of to make sure that the adolescents themselves are able to reach their own colleagues to be able to send the message across and create demand for the services. Over. Thank you.
Okay, I'll just have to ask for a short answer to that, Dr. Mushavi.
Sure. During the COVID, there was training material developed for community-based cadres. So we have village health workers, we have expert patients, we have other people like community-based distributors, for example. They were trained so that they had knowledge on COVID, and then they were also equipped, for example, to distribute HIV self-testing kits, which was really scaled up during the COVID, as well as to distribute family planning commodities, to talk about COVID-19, PPE, vaccines. So there was a training package put out for them, and then they were utilized to be the feet on the ground within the communities because people could not come always to a centralized setting to access services. And then in terms of the integration that you speak to, we are trying, even within DREAMS and other initiatives through the National AIDS Council or PEPFAR implemented partners, to make sure that we integrate as much messaging as possible for those that are HIV positive. And then continuing with the work on HIV prevention in that subpopulation.
Okay. Thank you very much. With that, we'll have to close this session so that we can go on to the oral abstract presentation. So thank you very much.